Parent management training is an intervention in which parents are taught social learning techniques to change the behaviour of their children or adolescents. It does not include every treatment that involves parents. Parent management training must include a conceptual view about how to change behaviour, which is based on operant conditioning, and a set of principles and techniques, which are also based on operant conditioning. It must also focus on the development of specific skills in the parent through role play and other active methods of training. Furthermore, it must also include the integration of assessment and evaluation of treatment. It is the most recommended evidence-based treatment for antisocial behaviour and oppositional defiance disorder. Parent management training began in the 1960s with an increase in research on the family as a contributor to clinical dysfunction. The initial goal was to teach parents positive reinforcement for pro-social skills and mild contingent negative sanctions for deviant behaviour. Parent management training is based on the work of Skinner, who believed that the best way to understand behaviour was to look at the causes of an action and its consequences. Skinner called his approach operant conditioning. This approach to parenting, for example ignoring tantrums rather than rewarding them with attention, was a popular approach to parenting in the 1960s. Gerald Patterson, a leading developer of parent management training, began collecting data in the 1960s to see if changes occurred as a result of the use of operant conditioning. His work included an extensive research project on aggressive behaviour in the home. He found that the ways parents gave commands, ignored pro-social behaviour, and punished behaviour contributed to coercion and helped escalate aggression. This work was critical in establishing that family interactions strongly influence child aggression. Patterson's early method was viewed as a simple educative process with little attention given to clinical sensitivity. Robert Waller, Constance Hanff, Ivar Lavasse, Sidney Bajau, Gerald Patterson, and Alan Kasdan are credited as being the leading researchers and developers of parent management training, and spent 2 decades adapting clinical procedures and methods of collecting data to determine if interventions were working. Marion Forgach undertook a study with 238 single mothers of boys who displayed antisocial behaviour. The study was undertaken working only with the mothers, as Forgach wanted to demonstrate the importance of the role mothers play in children's behaviour. The success was measured in part by how many of the boys were arrested over the next 9 years, and found that the vast majority did not get arrested. This study highlighted the importance of teaching parents through encouragement rather than correction, and finding the strengths of parents. It also found the relationship between the clinician and parent to be important. Parent management training was undertaken mostly in clinical settings up until the 1990s, and concern was expressed as to whether it would work in real-life settings. No official training was given to the clinicians who led the parent management training courses until, in 1998, the Norwegians wanted to begin a nationwide program and training courses were developed. Today, there are a host of parent management training programs. Some are undertaken primarily with individuals, such as Parent Management Training, PMT, and Parent Management Training Oregon, PMTO. Other programs, such as the Incredible Years program and the Triple P Positive Parenting program, use video vignettes in their instruction. Many of these programs combine the parenting program with a child program which builds self-regulation and social skills. Some programs are now undertaken in a group context or online. All of these programs aim to address children's behaviour problems by changing the relationship between family members. The underlying assumption in all PMTs is that both conduct problems and pro-social behaviour are maintained by repetitive relational patterns. The primary goal of PMT is to change the referral problem, but the initial goal is to develop the parent's skills and the child's responsiveness to their skills. The sessions are then broken down into 12 stages. The first of these is defining, observing and recording behaviour. In order to do this, the antecedents, stimuli, setting and contexts, behaviours and consequences must be understood in an in-depth and complex way. A systematic understanding of relationships enables the clinician to intervene. The sessions focus on the parent's skills and responses. Positive reinforcement is the central technique and is delivered after the target behaviour. In order for any reward to be considered a positive reinforcer, it must increase the prosocial behaviour. Conditional reinforcers such as tokens, which are exchanged for things, are commonly used. Punishment is rarely used, but when it is, it takes the form of removal of privileges, such as a timeout. More commonly, undesirable behaviour is dealt with by reinforcing other behaviour or alternate behaviour. Factors that influence the effectiveness of these techniques are that they are contingent, so only available after the desired behaviour, and immediate. Initially, the clinician asks the parent to focus on modest goals. They do not begin with behaviours which promote intense reactions. Eventually, though, the clinician works with the parent or parents to develop a sequence of positive behaviours referred to as chaining. When appropriate, the aim is for these behaviours to be maintained across different contexts, which is referred to as generalised behaviour. On the other hand, some behaviours, such as hugging to show affection, need to be understood as context-specific, which is referred to as discrimination. Each of the sessions have a review of the previous session and of the progress which has been made in between. Next, there is a presentation of a new principle or theme, followed by practice and role-playing. Finally, there is the addition of an assignment for the oncoming week. A therapist is available by telephone in between sessions. The Incredible Years program and the Parent Plus program are group programs. Along with the Triple P Positive Parenting program, they make use of video modelling and of recording themselves for feedback. The Parent Plus program used a bug in the ear where the therapist would give parents advice as situations occurred. Some programs also combine the parenting program with a self-regulation and social skills program for children. The Treatment Foster Care Oregon was a further adaptation by the Oregon Group, which is also available in other countries, including Australia. It combines short-term foster care placement, in which trained foster carers use the behavioural principles, while parents attend PMT. The Incredible Years program has now developed a computer-based online program, which has had positive response from 87% of parents and is confirmed to be effective in reducing child behavioural issues and increasing prosocial behaviour, as well as improving parenting strategies. Results of this program were well maintained at a 6-month follow-up. Kasdan claims that in the context of child and adolescent psychotherapy, there is probably no other treatment with such strong evidence in its behalf. Controlled studies show PMT has led to significant improvements in the treatment of oppositional, aggressive, antisocial and delinquent child behaviour. The majority of clients' behaviour returns to non-clinical functioning after treatment. Carr found that PMT leads to improvement in 60 to 70% of children and that these gains are generally maintained after treatment for at least 1 year. Furthermore, some studies show that gains are maintained up to 9 years after treatment. Kasdan's assertions are supported by a large number of studies, literature reviews and meta-analyses. Evidence suggests that certain factors affect the outcomes of treatment. These include the severity and duration of the child's behaviours, poor reading ability and school dysfunction along with comorbidities. Parent and family factors which affect outcomes include parent psychopathy, poor family relations, family stress and adverse child rearing practices. Contextual factors include low income, low socio-occupational and educational families and poor living conditions. It is beneficial to supplement PMT with other treatments particularly in cases where there are comorbidities. In response to questions about the effectiveness of PMT outside of controlled clinical situations, Mitchelson found that PMT was effective in a range of real-world practice conditions. Further research has been and is currently being undertaken in a range of situations. Online PMT is a relatively new innovation and has been found to be effective in reducing child behaviour issues and in improving pro-social behaviour. It was also found to improve parenting strategies. Results from this study were well maintained at a 6-month follow-up. Evidence suggests that certain groups have responded well to group-based PMT, teenage mothers and parents of children with ADHD, as well as some cultural groups responded well to group therapy. Evidence suggests that ethnic minority groups are associated with poorer outcomes. Adaptations for these groups are essential, but there is no single correct way to adapt for ethnic minorities. Studies have been done on programs where adaptations have been made. These adaptations have included surface adaptations, such as adaptations to the language and locations in which the therapy is presented, as well as the culture of the people presenting the therapy. They have included deep adaptations, which incorporate elements that influence behaviour of the target populations, such as cultural, social, and environmental adaptations. In their study of an early intervention program undertaken with Aboriginal Australians, Robinson et al. Found that it was not enough to tinker with cultural symbolism. They highlighted the importance of the perception of the therapy in the community, as well as the therapists having an in-depth understanding of the cultural expectations of child development and patterns of interaction between children and caregivers. However, it is important to note that results in this study were positive and improved with high attendance from the participants. Results generally showed a better improvement in the behaviour of Aboriginal boys than girls. Despite the amount of research which has already been done on PMT, more research is still needed. Areas for further research include research on adolescents, as most research focuses on 3 to 10-year-olds. More research is also needed on emergent therapies and emerging child-focused problems, such as internet gaming addiction. Further research is needed on adapting PMT for different cultural groups. Fergach gives the example of therapy undertaken in Uganda, in which one of the determinants for high parent participation was the supply of food rations to the participants. As the time for therapy cut into the time mothers would usually have collecting food, the supply of food rations allowed the mothers to participate. This example is used to highlight the unique adaptations required for different cultural groups. Moorick et al. And Robinson et al. Both state that the need for more research on and a process to guide cultural adaptations. Research suggests that PMT is most effective with younger clients and clients who participate voluntarily in the therapy. However, with appropriate adaptations, this therapy is appropriate for parents of children who display oppositional, aggressive, antisocial and/or delinquent behaviour. While, as has been discussed, success varies depending on cultural and socio-economic and educational factors, Fergach claims that positive results have been found in all the contexts in which the therapy has been undertaken. Some of the contexts she discusses include foster carers, incarcerated parents, single-parent family, and a wide range of cultural groups. Limitations in the use of this treatment include ensuring that therapists are trained and have a deep understanding of the treatment. There are also limitations on the effectiveness of this treatment alone in children who have comorbidities. When comorbidities exist, the treatment is effective when it is combined with other treatments. Parent management training is the most researched and effective treatment for antisocial behaviour and oppositional defiance disorder. It is cost-effective and able to be used in a wide range of contexts. While there are areas for further research and adaptations, this mode of therapy is extremely valuable to counselling and psychology.